Today we have today we have another interesting topic before us to discuss, which is CCI, chronic constriction injury, and we're going to be exploring different measurable markers and how we can improve, right, in researches around neuropathic pain. So today we have one of our lab members, a member rather, and a PhD student, Mr. Femi, Femi, who would be going through this topic of discussion and giving us some brief based on publications as well around this topic. So, Mr. Femi, I would give you the floor now to begin begin your talk. Then later on, we'll take questions and other comments too. So thank you.
Thank you very much, Prof. Thank you very much, Evelyn, for a good job that you are doing. This evening, I'll be talking about chronic constriction injury, just like you see on my slide. I hope my slide is very visible to everyone.
Yes, it is.
Thank you. So before I talk about chronic constriction injury, I want us to look at the normal scientific method. Yes, because we are talking about this is a lab method. So for those who are just joining or who are still doing their undergrad, I think it would be very good if they understand what lab methods are. So just like you can see on the screen now, the scientific method in neuroscience research, that's the first thing I want to talk about, which is very interesting. If we want to, this is a golden rule. Every scientific method must follow these characteristics and properties. So we have the first is observation, which is not a very difficult thing. You just observe something and you feel, okay, this looks like a phenomenon. And the next thing to do is you hypothesize, which is also called a scientific guess. I'm sure we've taught all of this in our biology classes when we're still in secondary school. It's not something, and in integrated science, as the case may be. So under hypothesis, you formulate a testable, falsifiable statement. Falsifiable there does not mean false. It means something that can be proven. So that's why it's called a scientific guess. And the third is experimentation, which is where I'm going to be talking today, because we can't jump to experimentation without the first two. So you have to observe, you have to make an hypothesis, and that's why we have the null and the alternative hypothesis. And the null is saying there's no significant change or there's no significant difference, as the case may be, for any experiment that we may want to conduct. So the third, which is experimentation, has to do with a design control. And the design must be reproducible. It must be something that can be tested and checked somewhere else to produce the same result. And it must have clearly defined variable. So this is where CCI belongs. And this is where we are going to be talking about that experimentation. Under experimentation, that method is under this experimentation. All the topics you find published all started with an observation, then there was an hypothesis, then there was an experimentation before the next, which is data collection, whether systemic, blinded, qualitative, quantitative. I know one of these days, maybe somebody will talk about all of these things also. Then we have the analysis after the data have been collected, they are analyzed, and there's a conclusion. And under the conclusion, you either reject or accept the hypothesis. Then what you've gotten from our experiments can be published so that we can add to knowledge. If you see underneath, I wrote the key scientific property: objectivity, reproducibility, falsifiability, peer review, ethical rigor, and transparency. So this is the third basic neuroscience laboratory method. I just put here some of the neuroscience lab method, because we are talking about lab method, under which CCI is just one of them. There are many. So we have functional methods that deals with the use of electrophysiology, electromyogram, electrocardiogram, electroencephalogram. All of these falls under, but for us, we are using encephalogram really, not the and myogram, so that we'll be able to use electric, we'll be able to measure electrical signaling in neuroscience research. Then the next is structural laboratory methods. That's where we have histology and immunohistochemistry, where tissues are stained and cells are identified, protein expressions are seen, and structural changes can also be checked. Then we have molecular methods, which include Western blot analyzer, where proteins are quantified and detected in nervous tissues, cytokines, kinases, and ion channels. Then we have behavioral assay, where we have the use of free filament, Hargreaves method, rotarods to assess pain sensitivity, motor function, and cognition in rodents. In our lab, here we have, by the grace of God, I published papers. Our PI prof has published papers using many of these, many, if not all of these behavioral assays. Then we have imaging too. And the last is the surgical method, the surgical laboratory method, which involves stereostatic surgeries and the use of electrodes to see deep brain structures. So underneath, I put that these methods work in combination. You have CCI surgery, for instance, because CCI is a surgical method, because something has to be cut, something has to be exposed, it's a surgery to be done. Then we check the effectiveness of that surgery through behavioral assay. Then we can use immunohistochemistry to quantify certain proteins, and also Western blots, and we can make use of electrophysiology too. So these methods works hand in hand, and they work best synergistically and in combination. So now let's go to the topic of the day, which is CCI. It was, thank you for asking me to do a little research on this topic, because when I was searching, that was when I discovered that there are two CCIs. And that is why I put here the third one. Sorry, the third slide is what is CCI? A tale of two acronyms. So CCI, we have chronic constriction injury, but there is another one called controlled cortical impact. So in clarifying this disambiguation, I want to talk about the two, because anytime you hear CCI, you have to ask what context or which of the CCIs are they talking about. So there's one called the chronic constriction injury, CCI, which is used, the domain is in the peripheral nerve and is used for pain research, just like I'll be talking about in a few minutes. And the model is to use the sciatic nerve ligation. So we use sciatic nerve, we ligate the sciatic nerve. How? Is it loosely? Is it tightly? So we're going to get to that in a moment. Then the purpose of chronic constriction injury is to induce neuropathic pain states. And neuropathic pain is either chronic or acute. And for this, we are talking about the chronic, because it's chronic constriction injury. So we are talking about the chronic neuropathic pain. And if we are going to very fast talk about that too, chronic neuropathic pain in humans is common. It's common in 7 to 10% humans. So that's why it's an aspect of pain research that needs, something that affects 10% of people suffering from one pain or the other needs to be researched. And it's called chronic because it extends for months, sometimes more than 3 months. And the origin, who propounded this, who started with this, was Bennett and Z in 1988. That's the origin of CCI, the chronic constriction injury, the one that is meant for peripheral nerve, nervous system, and the study of pain in peripheral nerve, which I said is make use of the sciatic nerve, which is the largest and the longest nerve in the body. And we have The output, what do we use this to do? We check allodynia, we check hyperagresia, and allodynia is just explaining phenomena that naturally should not trigger pain, that triggers one. We want to also talk about hyperagresia, which is excessive reaction, sensitivity to pain. So that is the main focus today. But there's a second, which we must not forget too. That's why I said we should ask, what is the context of the CCI we are talking about, which is the controlled cortical impact? And they use this in traumatic brain injury, TBI research. And the model is to mimic impact strike on the cerebral cortex. And the purpose is to model traumatic brain impact, which includes contortion, edema, and axonic injury, which affect the cerebral cortex. And this originates, or this was propounded by Dixon et al. In 1991. And the output is used to measure motor deficits, cognitive impairment, and cell death in the brain. So the context is used in brain injury labs. So both of these are valid neuroscience models. And so the context determines which CCI that we are talking about that is meant to be used. So this presentation today will focus on the chronic constriction injury. So what's the difference, very fast, before I leave here, the difference between this and why they matter in neuroscience? So these are the two, just like I explained, the nerve targeted for CCI, for chronic constriction injury, which is the one that we're talking about this evening, is peripheral, which is the sciatic nerve. But for controlled cortical impact, which is another CCI, so most of the time they put CCI pain and CCI TBI just to make a little, just to understand which one we're talking about. So the nerve is central, the cerebral cortex is talking about the cerebral cortex, that's where we are talking, not the peripheral nerve. Then the injury mechanism. In CCI, there's a loose ligature, which leads to chronic compression, not a total obstruction of blood flow to the tissues. But in CCI, which is for the brain injury, we have, it's an electromagnetic impactor. So they use an electromagnetic impactor. And the primary readouts, allodynia, thermal, and mechanical hyperagresia in chronic constriction injury. Why for controlled cortical impact, we have motor scores, cognitive tests, and histology. These are things that they use. So the pain components for chronic constriction injury is the central and the peripheral sensitization. Why for controlled cortical impact is secondary inflammation. And the glia movement is in chronic constriction injury is in the spinal cord. We're talking about the microglia and astrocyte. Why for the brain injury, brain injury, we are looking at the cortex, the hippocampus, and the astrocytes and microglia in the brain, not in the spinal cord. And the clinical relevance for chronic constriction injury is that it's used for neuropathic pain, which is largely studied and largely researched about at the neuroinflammation lab. But for cortical control impact, we are talking about traumatic brain injury, stroke, neurodegenerative sequelae too. Now, the reason why I'm trying to add this today so that we see the difference, because I'm sure that in our lab, maybe one of the students may decide to do something around this in times to come too. So, species is used for chronic constriction injury, CCI, is basically rodent, rats, Sprogdali, Wister. But for CCI, most of the times, there's a use of mice and rat. So let me go directly to chronic constriction today. The definition, how it is induced, and the application. The definition. So the chronic constriction injury, just like it sounds, chronic constriction is a rodent model of peripheral neuropathic pain in which the sciatic nerve, which is the largest nerve in the body, which extends from L4 to S3, is surgically exposed and loosely ligated with chromic gut or six suture, producing a partial chronic nerve constriction. So the nerve, the sciatic nerve, is constricted. Don't forget, from our knowledge of anatomy, the sciatic nerve has two branches. It has the it has a tibia and a fibular branch. So before the branching, the sciatic nerve is tied loosely, is ligated loosely, so as to cause a partial chronic nerve constriction, which will lead to neuroinflammation, which can also lead to axonal death. And the induction induced, the animal is first anesthetized using isoflurane. I think in our lab, we agreed last year in one of the sessions that isoflurane is better. It was agreed on to be used. Then we have ketamine and others too. Then the sciatic nerve is exposed mid-thigh, at the mid-thigh level. And before you get to the sciatic nerve, you have to identify the gluteal muscle and the bicep femoris before you get to the sciatic nerve. Then after this, place a 4 loose chromic gut ligature, then close the incision and allow for recovery. So why is this important? Which boils down to the mode of what the model mimics. So this mimics clinical neuropathic pain, post-surgical pain, diabetic neuropathy, and chemotherapy-induced neuropathy. So this method is used to mimic that which happens in human. But this is a lab method which we can perform on rodent to understand the physiology and the mechanism of the spread of the pain, and also to see if we have any drug or any substance that can be used to study how this pain can be mitigated. So the time course, pain behavior emerges at the 3 to 5, peak at the 7 to 14, and may persist for close to 4 to 8 weeks, enabling both the acute and the chronic study window. So by the side here, we have the sciatic nerve ligation. Those are the four loose chromic gut ligature, which we are going to be talking about in a moment, why they are important and what can happen to this ligature. So the consequence of this constriction, of constricting the blood vessel, the nerve supply to the muscle, because the sciatic nerve supplies the limb, it supplies the leg, it supplies the hind limb of animals, and in humans it supplies the the muscles from the femur down to the leg, so to speak. Now, so what will happen when this constriction is done? The first is that there will be perineural edema and ischemia, which is decreased oxygen and blood supply to tissue. Then there will be progressive axonal degeneration. I spoke about that the other time. And there's demyelination of nerve fibers, which may trigger the release of tumor necrotic factor alpha and interleukin-1 and interleukin-6. And there's also a central sensitization at the spinal cord. Now, the history of neuropathic pain models before and after CCI. Just like I noted the other time, CCI, which started in 1988 by Benny and Z, before then, there have been neuropathic pain models. In the 1940s and 60s, there was a Wallerian degeneration studies. And before this time, which is a complete nerve transection with no functional pain read out possible, because there was already a complete transection. So after that, there was another model called the autonomy model, autotomy model, which was prescribed by Wall et al. In 1979. These are self-mutilation after nerve transection, but it had poor clinical validity, and the pain also was a major concern to the general neuropathic pain study world, because the animals were not well taken care of because there was a lot of pain. So after that, in the same 1979, there was a tight sciatic ligation by Bashburn. Now, the reason why I'm taking time to talk about all of this is that the CCI that we have now, which is the chronic constriction injury model, was just an improvement over the 1979 model, which was a tight ligation. So in 1988, the CCI model that we have now, which was talked about by Bennett and Z, is a loose chromic gut ligature on sciatic nerve, which produces allodynia and thermal hypergeusia. So in 1992, there are other models now which are built on what Benny and Z also built, the Setzer model, BLS, partial sciatic nerve ligation, which is also a tight suture through half of the nerve diameter. And there's a 1994 model, which is part of the papers that Prof sent to the platform. They use this SNI. There's SNL, spinal nerve ligation, which involves the L6, L5, and the L6. And in the 2000, around 2000 and 2001, there is this last one called XNI, the speared nerve injury. So one of the papers used this SNI, and we are going to get there in a moment from now. Now, the CCI model, what are the advantages and the disadvantages? The CCI model has been used extensively in our lab. There are published journals. In fact, it's called the commonest, the most popular of all the chronic of all the models for peripheral pain study, because it's that singular publication has generated over 10,000 citations since when it was published. So the advantages is that the clinical relevance, it's finely exactly mimics peripheral neuropathy, entrapment, post-surgical, diabetic, pain due to strangles, etc. And also it is reproducible. When I was talking about scientific method the other time, I talked about reproducibility. So it's a standard protocol, comparable across laboratories worldwide. Anybody can use it and reproduce the same result. And the third one is that it has rich behavioral output. That is, after it has been induced, the behavioral methods used to assess the condition of pain, allodynia, thermal and mechanical hypergeusia, motor asymmetry, they have always produced a very rich behavioral output. And also the internal control, the contralateral limb serves as the within animal control. The contralateral means if the procedure is done on the left limb, there's a right limb that can be compared to know how the pain is going on the right limb. So just the contralateral, the opposite. Then we have the chronic pain window. So this also gives room for sustained window pain. So it can be used to both measure acute and chronic pain reaction in animals. And there's a sixth advantage, which is the multi-tissue access. So it gives room to assess the DRG, the dorsal ganglia, the spinal cord state, the supraspinal cord, and also blood sample can be taken to check for certain parameters to be measured. So a few of the disadvantages, which are still not talked about a lot, is the surgical variability. And this is what I was talking about the other time when I was talking about the looseness of the suture of the ligation. Now, how do we know how tight it should be? So this suture tightness varies between surgeons or operators. And it is very critical because maybe two people are doing the same thing. Somebody ties his own too tightly, because there's no significant measure of how, people just take initiative of how tight it should be. So that can be a problem if it is not, if the animals are not operated on as it should be. If the person is too hard on them, so it can affect the result too. The chromic gut degradation. Suture dissolves over time, and pain phenotypes timeline may shift. So if the suture is weakening because it's loose, it may affect the output of the research. And the animal welfare, significant pain and distress, which an ethical rule we are trying to reduce. Then the species limitation. This is most valid in rats, mouse, because of their size of the body. Some people use it, but it's been proven to be less consistent in mice. The spontaneous pain is hard to measure directly. We have to rely on indirect behavioral indices. That's why we have allodynia, that's where we have the Agrips method, that's where we have the hyperagresia means too. And the translational gap, which is very important. Rodent allodynia is not always equal to human neuropathic pain. Mechanistically, yes, but clinically, it may not be the same. Okay, so from here, I will go to the measuring CCI effective. How do we ensure that we are using this method effectively? We have behavioral assays that can be used to read the effectiveness of the pain. We have the molecular readout, the refinement, and the horizon technologies. So we have mechanical allodynia, which is very interesting. It's one of, I saw in Isu and WLA in 2020, that many of these, also in Bakari and WLA 2022, many of these were effectively used. So for the mechanical allodynia, the Fomfrey filament is used. And the Fomfrey filament, they are not necessarily painful, but they are used to measure the the effect of the pain that was inflicted on the animal. Then we have the thermal hyperagresia. Hyperagresia means excessive sensitivity to thermal sensation to heat. So we have the cold allodynia too, which is measured using acetone evaporation test, and the effect is pore leaking and lifting response. Then we have others too, the spinal cord immunohistochemistry, which have been used in some of our journals in the lab. CFOS, GGAP, IBA1, all of these are central sensitization markers. Then the Western blot, we have measured, or we can still measure if we want to do it again, tunnel necrotic factor. These are measured in some of the journals that have been published in the lab. We have interleukin 1 beta, we have sodium voltage 1.7, 1.8 at the DRG and the spinal level. Then we have electrophysiology. And we can use ELISA too, and proteomics. These are new things which measures CSF cytokine and can profile what is happening post and pre-CCI. So what are the improvements that can be done in the future? Now, the first, just like I talked about the 6 structure the other time, if there's a standardized suture calibration to know how tight, how loose the tightness should be, the constriction should be. Then maybe there can be an AI-assisted behavioral scoring. And in our lab, there's neurosyntax what's the name that has been developed. Maybe we can develop more to score these behavioral tests. Then sex stratified study, which means maybe the male and the female cohorts can be measured differently to see, because in two of the journals that I'll be talking about very soon, there is one where only the male contingent, male animals, were used, and it was stated there that the female, they don't want the sexual, the cycle to affect pain. So optogenetic integration, real-time silencing, activation of nociceptive receptors, single RNA sequencing, and also drug screening platform. CCI can be used, which is still being used to check for novel analgesic effect of compounds. So this is CCI explained. So now I want to go very straight now to the the three uh the three the three papers we are reviewing which has this method, because it's very important that even though we have explained the method, we want to see a show of how it has been used in journals, and that is exactly what I'm going to be displaying right now. So there are three papers here. There are three papers here. One from Iran, one from Japan, and the other one from Cameroon. I hope you can see my slide, my screen again. So this is the first one, which measures mirror image targeting glass activation to mitigate mirror image and extraterrestrial neuropathic pain. Now, what is mirror image? What is mirror pain? And what is extraterrestrial neuropathic pain? Now, in this, I would like to explain just the method used in this research. Now, but for the sake of knowledge, mirror pain is very simple, just like the mirror effect in physics, which is lateral inversion. That is, if somebody faces the mirror, the right becomes the left and the left becomes the right. So also, when in this particular journal, the animal model uses CCI. That is it up there. That is it up there. So it's majorly, there are only male Wister rats in that, and they were trying to check the effect of minocycline, which is a vasodilator, and pentoxifylline. Now, what mirror pain means is this: when the ligation, the CCI ligation, is done on the left leg, on the left limb of the animal, the same pain can be felt on the right where nothing was done. So that means the right limb as a mirror of what has happened in the left. And this is traceable to the way the spinal cord is designed. That is, pain can be transferred, can be read contralaterally from the left to the right. So this, in this particular protocol, CCI was used, and the same, they use four, you can see right sciatic nerve, four loose catgut ligature, according to Bennett and Z in 1988. They had a sham group, and they have the group where they applied the two drugs, monocycline, 10 milligram per kg, and pentoxifylline. And the behavioral test, just like I spoke about the other time, with the aggressive test, which is the thermal hyperglycemia. This means that animal that has, if they test positive here, animals they will react to pain faster than they should have reacted if there was no CCI done on them. So let's imagine that they should have, if they are meant to react after 7 seconds. In this, if after CCI, they will react very fast, maybe at 4 or at 3, if they test positive to thermal hyperglycemia. They have Then the von filament was used to check the mechanical allodynia. And the third one was the tail flick to check the extraterritorial pain. So what are extraterritorial pain? This is another important type of pain which can be studied anytime. Now, extraterritorial is different from the contralateral or the mirror pain, mirror image pain. Now, in extraterritorial pain, it's talking about feeling of pain where the injury, the nerve that was severed cannot even supply. So, for instance, if after the induction on the right limb, if there is pain in the stomach or in the abdomen, which is a place that is not even from the same origin as the nerve that was ligated, then that is called extraterritorial pain. That means a pain from another territory entirely. And for this design, they made use of Western blot, just like I said the other time, that after CCI is done, there are a series of other things, behavioral testing, Western blotting, that should be used to further understand the effect of the CCI, the chronic, the CCI that has just been in. So we have the result from there is that the contralateral, there was on the contralateral side of the animal, there was a decrease in pain because of the administration of the two drugs that was used. The Pomfrey test also showed mechanical allodynia. So the time is the time was reversed, so it was not as the drug worked to reduce the pain on the contralateral side. And the tail flick also test was used to measure the extraterritorial pain. Because, I said the sciatic nerve supplies the limb, the hind limb. So if there's still pain in the tail, that means it's extraterritorial in animal. And also they use Western blots to further get other things to discuss. So this their discussion, which is not really necessary for this because we are just talking about the method. Now, this other paper from the Department of Anesthesiology and Resuscitology in Okayama University, Japan, measures the adrenergic antagonism of the upregulation of spinal GLT1, which ameliorates mirror image pain. Now, in this particular research, they made use of SNI, not CCI. And that was why I said the other time that all of these are meant to complement each other. All of these are meant to complement each other. This is what some researchers have been using now, the spared nerve injury. What happens here is that they cut 2 out of the 3. They leave just out of the 3 branches, they cut 2 and leave 1, which is what and here they tested it against phentolamine. So they were trying to mitigate mirror image pain. That is, if there's a pain on the right leg, if there's a pain that is generated on the right leg, there should not be pain on the left leg. So this is exactly what they use. This particular journal is talking about. Now, what are the key things they did there? There was an in vitro and an in vivo test. So for the SNI model, which we are bothered about, the left tibial nerve ligation, there was a left tibial nerve ligation. So this is SNI now and not CCI, which is the spared nerve injury. That is one of the nerve branches is left, which is called the sura nerve or something like that. Then there's a drug protocol. They injected phentolamine and they tested using the behavioral test. They used the Pomfrey to check the mechanical allodynia. And these are the things that happened there. The GLT1 protein in the SNI rats, they check ipsilaterally and contralaterally, and they decrease. And if that decreases, that means the pain also is affected. So the pain is not as severe as it should have been. So in this particular review, they made use of SNI. And this is the mechanism that they proposed, that there's a noradrenaline surge, which helps to partially cause relief in pain on the other limb that was not constricted. So that is that on this. Then the third paper, which is something really very related to my work, is tramadol-induced addiction shows sex-dependent variation response in pubescent adolescent Western rats. And this was conducted not too far away from Nigeria. It was conducted in Cameroon by Nkwaye et al. And because this is not actually a pain research, it's an addiction research, so to speak. So what these authors, these scientists were trying to check is if early exposure to tramadol, they use 50 milligram per meal for each animal here. If early exposure to tramadol can cause addiction before puberty. And the result showed that, yes, it is possible. So this is the animal model. They use pubescent Western rats, which are just 40 to 42 days old, 14 female and 14 males. And these are the preconditioning. They made use of another method here called the conditioned place preference, CPP. And the animals were preconditioned and they were tested using elevated pulse mace to check hyperactivity. And also there was a biochemical examination when in the striatum, the hippocampus, to check what happens to the brain to cause addiction or not. So the CPP showed that in both sexes, the animals always preferred the tramadol room, but it's more in female than in male, which is consistent with many other research that has done that. Then the elevated pulse mace also showed hyperactivity in female more than in male. Then also they check dopamine, the feel-good hormone. So it's also in the animals, in all the animals, there was increase in dopamine level especially in striatum, and there was a decrease in GABA. GABA is an inhibitory hormone. That means there was no inhibition. What makes men to stop? What makes them to stop repeating something? So there is low level of GABA. That means they don't have a control over the love for tramadol. Then also they check for nitric oxide in the brain, which showed that there was stress. The brain was stressed. They checked the oxidative stress marker, MDA and nitric oxide. So that's that about that. So at the end of the day, they proposed that, probably estrogen drove the difference between male and female. And their work was great, but I think their future direction pointed to the fact that, okay, why not try it in adult animals instead of pre-pubertal animals? Why? Because a lot of times it takes adulting sometimes to want to either take tramadol or not. So this will be the end of my presentation today. I've spoken about CCI and the two types that we have found to exist as at this time. And also I spoke about how anytime we want to talk about CCI, we must talk in context of which one and which one that we are not talking about. So thank you very much for listening. Thank you and thank you. Back to you, Evelyn. Can you all hear me?
Yes, we can hear you. So hopefully Evelyn comes on. Well, we
Thank
heard you very clearly.
you. Okay. Thank you very much.
Uh, Evelyn?
Good evening, sir. I think our network is bad. She chatted me up, sir.
Okay.
Oh, okay. Well, so do we have any question to ask Mr. Onolopo? So maybe Adebimpe can moderate in a way. Any question?
Okay, sir. Thank you, sir. And thank you for the opportunity. Mr. Femi, thank you very much for that brilliant presentation. And the floor is open for anybody that wants to ask questions based on what he has just presented and he has told us. You can please raise up your hand and we'll call you to ask your questions. And if we have any further thing to add to it, you can please signify. Thank you.
So let me ask if is there any advantage of CCI over SNL, or what do you think are the basic differences?
Okay. Thank you, Prof, for that question, sir. Well, I think the basic advantage of CCI, apart from the fact that is more, because it's still till date is the commonest way of generating neuropathic pain. So the SNI, which wants to be an improvement, is not, a lot of people have not started using it. And their reason is not far-fetched, those who are using it, than some of the disadvantages I stated concerning the CCI model, that the suture tightness, a lot of people are not comfortable with, okay, how tight should it be? And also the second one, I talked about chromic gut degradation, that what if the tightness loosens and the animals have been sutured off up and we don't know? So these are some of the things that, but for SNI think it takes care of that, because speared nerve, two are already cut. So there's no need to think about maybe something got loosened or how tight should it be. That's the only major advantage it has over CCI model. But CCI is still the most acceptable at this point, and that's what a lot of researchers are using till date, not the speared nerve injury. Thank you very much, sir.
Yeah. Did you come across the modified CCI, like you have the partial sciatic, nerve ligation?
Yes, sir. I explained that when I was talking about the 1992 model. The partial sciatic nerve ligation was proposed in 1992. That's 4 years after the CCI model. So, but the suture is tight through half of the nerve diameter. So one of the things that some researchers have against that also is that, how do we have to start measuring half the nerve diameter? That led to, okay, maybe we should go to SNL, which is the next one that came out in 1994, which is spinal nerve ligation, which is everything. And the advantage of that, they said, is because there's a dermatoma specificity, because when they tighten up the whole spinal nerve, at L5 and L6, maybe there won't be a need to be bothered about the partial ligation too, the tightness, before they now, in 2000, now started using SNI. So there is a partial sciatic nerve ligation which was proposed just after CCI, but still, a lot of people prefer CCI to the partial sciatic nerve ligation, which is also called the Caesar model. That's the name of the person who discovered it. Thank you very much, sir.
Yeah, I hope other people are going to ask one or two things. Did you compare the mirror neuron publication?
Mirror, yes,
Yeah,
sir.
mirror image neuron publication with some of our publication, and especially look at the style of titling, putting it in terms of, I mean, and it's like virtually what we do, but then what makes it a bit, what can justify giving that title to that paper compared with like virtually all what we do, and we don't even go to that extent of thinking about saying we are looking at a mirror neuron and what have you.
Okay, I think we are doing a great work, but here they just maybe they just added a bit of intuition to check what is even happening with the other leg that is not ligated. There's nothing special, so to speak, about this other paper, because they are just trying to see that after the ligation of one leg, what happens to the other leg. And just like I said, the mirror image pain has been proven to really affect a few people. So that means at the spinal level, pain from one leg can spread. That's exactly what is a kind of contralateral. That is, pain from a level can. So I just think in some of our research we can include these too, to check are there changes on the other leg, and also we can check on the forelimbs too, if laterally. That is, if we ligate the right end limb, for instance, is anything happening at all in the right forelimbs too? And since it's just the same protocol, we are going to use the same behavioral method, we are going to use Pomfrey, but not on the induced leg now. So I think we can just try and add this also to some of our pain research to see, is it even true that something might be happening to the non-ligated leg, if laterally or contralaterally. So if we do that, we'll be able to know, or to speak to, or to write about mirror effect, if it truly happens, or in fact, it may also be a kind of confirmation that the leg that was induced with CCI, if others prove that there's always something happening on the left leg, on the other leg, then we can try and look at it. Okay, if it's not happening in our own, could it be that something had happened to the suturing? Could it be that something had happened to the induction? So that may help us to just gather some points on how, if, and probably what happens at the spinal level with pain. Thank you, sir.
Okay. Sorry, maybe I'm taking, is there anything that they have done that we cannot do? I think there's the only thing that is a bit new is Western blot. And is there anything in that paper that they have done that you think our lab cannot do?
No, not at all. Not at all. Because from here, we have only the behavioral testing. We are already doing all the 5. Okay, and the extraterritorial pain too. The extraterritorial pain is simple, but I don't, the tail flick, it can be done at any time. We can do that. I think we have done that before. The Western blot on the L5 and L6, that's the only thing. Other things we have, I think we have done that. And also, maybe, I don't know if anybody, under the Western blot too, I remember the day I was defending my proposal, the external examiner talked about this IBA1 and this particular expression. So maybe when we do the Western blot, we have more reports about some of these things too at the spinal level. So, but there's nothing they did that we cannot do. And on their future direction, what they wrote at the end of the paper, what they just spoke about the drugs that they use, not the method. I think that's all. And okay, there's another one which states that in the future, maybe they will have extended, they will have compared what happens in a male rat with what happens in a female rat. That's all. So there's nothing they have done that we cannot do, sir. I don't think there's anything.
Okay, that was fair enough. Thank you. Any other I don't know if there are, let me allow any other question.
Thank you.
Is Evelyn
Okay,
back?
thank you, Mr. Femi. I don't think she's back, sir. Yes, thank you, Mr. Femi. I just want to ask one question. And my question is, in human beings, they talk about referred pain. And
Yes.
sometimes it gives issues when they actually want to prescribe or tell them what to use, because it's actually the right leg that is actually affected, but they feel more of the pain at the left leg. So just like Prof said, I think,
Okay.
would you not feel like our next pain research that I'll be doing using neuropathic pain, I'm using CC. I think we should also check for the markers also at the place where we did not like get them, and see if actually there are some depositions of inflammations or stress there that's actually causing that pain. Yes, a referred pain, but at least we'll be able to rule it out that, well, maybe it's just some sensation, or practically it is even that leg that actually needs the treatment so that the leg that is actually ligated can be healed. Or what do you think, sir?
Okay, thank you very much, man. Yeah, when I was talking about the history of neuropathic pain, I remembered I spoke about the spinal nerve ligation. Now, referred pain from normal basic physiology means that the pain is felt in a place that develops the nerve. For instance, it's due to dermatoma rule. That is, if two organs develop from the same dermatome, so pain from one can be referred to the other. But just like you have noted, what you said was the right leg and the left leg is the mirror pain, which Prof was talking about the other time. For referred pain, we have to be sure first if the two organs or the two parts of the animal's body develop from the same dermatome. Now, and that is why in 1994, that SNL, spinal nerve ligation, that was why Kim and Chung developed that model. When I was reading about it, they said it's because it has more dermatoma specificity and is preferred in some pain labs today. Now, what they were trying to do is that they were trying to say, okay, when we do a spinal nerve ligation, that is not loose now, not partial, a total spinal nerve ligation. They are trying to say when they ligate the whole spine at that level, all the organs that develop from that same nerve, that same nerve supplies will be affected equally. So just like you said, there's nothing. That's why it's called research. We can try that to see if we use CCI2, will there be a mirror effect? Will there be a referred pain? But if we are doing referred pain, that means we may do the leg and check abdomen. So we just try and do the physiology. Which organ develops with this part of the body? And we check for the referred pain there. Just like in man, if somebody has a heart pain, it can be felt on the, I think the left shoulder, because they both develop from the same embryonic dermata. Thank you very much.
Yeah, thank you, sir. And thank you for the presentation. And I think we'll need to improve more on our pain research and try to see if we can modify it more and make it more better. Thank you.
You're
All
welcome.
right, so thank you, Femi. That has been a good presentation, thorough research, and
Thank you very
I think we need to do more because we need to improve, and we need to see because one of the journal that the article you review was in a very standard physiology journal, and as we move forward, we want to publish in very good, very high impact journal, and we want to see what people have done and what made their work to be acceptable in such journals, and can we actually replicate them in our laboratory? And is there any new thing we can learn from them and to modify and improve our workflow? So, and I think you've done a lot. I know you have got like two articles which are pain, and then another one that is on addiction. And of course, you could just have just major on addiction. But I'm sure that you're going through the three articles has been of help to you too. You have learned quite a lot. And even in the pain articles, even though you are primarily looking at addiction, you probably have gained one or two things that can enhance your work.
Yes, sir.
Okay, all right. So, ladies and gentlemen, we want to thank Femi, a PhD student of the department, for this presentation on lab method, and want to thank every other people that have attended, and thank you for your time. And I believe that you have gained one thing or the other. This is recorded, so we'll likely have it on our YouTube platform very soon. Dr. Patrick is here, and Dr. Turila is also here. Dr. Turila is the head of the Department of Physiology at the Bingham University. Okay, he's just gone now. Well, he was here. Ogbe, thank you, and other people, thank you for coming. And we do believe that you have gained one thing or the other. So, bye-bye.
Thank you. Bye bye, sir. Thank you, sir.